Hello, my name is Brent Reed, and I'm a member of the ATRIUM Cardiology Collaborative here at the University of Maryland. This is part of a series of videos that we've put together on hypertension. In this video, we'll be discussing two classes of antihypertensive drugs, the angiotensin-converting enzyme inhibitors, or ACE inhibitors, and angiotensin II receptor blockers, or ARBs. Now, since these two drugs work in very similar ways, you'll often find me referring to them together throughout the rest of this presentation. Now, ACE inhibitors and ARBs are two of the most common drug classes used for the treatment of hypertension. And as you can see from these lists, there are a variety of options available. Now, ACE inhibitors are distinguished by ending in the word pril, such as lisinopril or enalapril, whereas ARBs are distinguished by ending in the word tan, such as candesartan or valsartan. Now, ACE inhibitors and ARBs work on different parts of the renin-angiotensin-aldosterone system, or the RAS. Before I discuss where these drugs work, let's briefly review the RAS and how it can increase blood pressure. Now, the RAS is activated as a normal response to low blood pressure, but in some patients this system becomes abnormally active, which is what leads to chronic hypertension. Now, the kidneys release renin into the bloodstream in response to low blood pressures. Now, this converts circulating angiotensinogen into angiotensin I. Angiotensin I is then converted into angiotensin II by the angiotensin-converting enzyme, or ACE. Now, angiotensin II is one of the body's most potent physiologic vasoconstrictors, and it can bind to angiotensin II receptors on vascular smooth muscle to increase blood pressure directly. Additionally, angiotensin II also binds to angiotensin II receptors in the adrenal cortex, which stimulates the release of aldosterone. Aldosterone promotes sodium and water retention, which can increase blood pressure by increasing blood volume. Now, ACE inhibitors inhibit the ACE enzyme, preventing the conversion of angiotensin I into angiotensin II. This prevents the actions of angiotensin II on both vascular smooth muscle as well as the downstream activation of aldosterone release. Now, ARBs work one step downstream of that process by blocking the binding of angiotensin II to receptors on vascular smooth muscle and in the adrenal cortex. Now, because of these similar mechanisms of action, ACE inhibitors and ARBs share many of their pharmacologic effects, both the beneficial and adverse effects. There are a couple of important differences, however, which I'll cover in more detail when I come back to adverse effects a little bit later. Now, in terms of dosing and administration, with the exception of enalapril, all of the ACE inhibitors and ARBs are administered orally. However, the dosing and frequency of each agent depends on the agent that's used, as you can see here on this table. Now, feel free to pause here or screenshot this table if you'd like to review many of the most common ACE inhibitors and ARBs and their dosing. Now, since these drugs have very similar effects, selection of a specific agent usually depends more on patient or clinician preference, rather than any differences in their safety or efficacy. Either way, regardless of the agent that's selected, therapy is usually initiated at low doses to ensure that patients can tolerate it, and then the doses are gradually doubled every 4 to 6 weeks until goal blood pressure is achieved. Now, in terms of their contraindications, ACE inhibitors and ARBs are contraindicated in pregnant women because they can cause harm to a developing fetus. Now, for these same reasons, use in breastfeeding is often avoided as well. Therapy should also be avoided in patients with bilateral renal artery stenosis, a condition in which blood flow to the kidneys is reduced. ACE inhibitors and ARBs interfere with the kidney's counter-regulatory response to this decreased blood flow, which could otherwise result in acute kidney injury. Now, in terms of adverse effects, the most common adverse effects that ACE inhibitors and ARBs share are hypotension, which may manifest as dizziness, hyperkalemia, and acute kidney injury. Now, two adverse effects that distinguish the two are higher rates of cough and angioedema associated with ACE inhibitors. Now, to understand why, let's briefly take a look back at the mechanism of action for these two drugs. In addition to converting angiotensin I to angiotensin II, the ACE enzyme is also responsible for the breakdown of a variety of inflammatory mediators, including bradykinin. So by inhibiting ACE inhibitors increase bradykinin concentrations, which are thought to be the underlying etiology for the increased rates of cough and angioedema seen with this drug class. Now, even though it can occur, angioedema is very rare. It only affects about 1 out of every 1,000 patients, although rates among those of African descent may be about 2 to 4 times higher than other populations. Now, cough is a little bit more common with ACE inhibitors, as this affects about 3 to 4 out of every 100 patients, but therapy only has to be stopped if the cough is bothersome. Now, unlike ACE inhibitors, ARBs work downstream of the ACE enzyme, and therefore they're unlikely to provoke cough or angioedema, although it may occur very rarely in some patients. Now, in terms of monitoring, aside from blood pressure monitoring, most of the monitoring of ACE inhibitors and ARBs relates to their adverse effects on the kidney. So for this reason, renal function should be monitored by checking a serum creatinine and a BUN at baseline and within 1 to 2 weeks of initiating therapy. Serum potassium concentration should also be checked along with renal function. Now lastly, in terms of drug-drug interactions, most of the interactions with ACE inhibitors and ARBs are pharmacologic in nature. As a result, both classes should be used with caution in combination of drugs that can cause kidney injury or that can increase serum potassium concentration. And because of this reason, the two classes should generally not be used together, except in very, very rare instances, which are really beyond the scope of this discussion. So that concludes this overview of ACE inhibitors and ARBs when they're used for the treatment of hypertension. Now don't forget to check out the other videos in this series, and again, thanks for stopping by.